Good evening, ladies and gentlemen. A very warm welcome to all our esteemed faculty members, colleagues, and participants joining us today. It gives us immense pleasure to welcome you to Onco Edge Redefining Cancer Care, a focused academic platform designed to bring cutting edge evidence, global updates, and practical insights together right at the point of care. Over the next 2 days, we will explore evolving paradigms across breast, lung, gynecologic, GU, GI cancers with a strong emphasis on recent landmark trials, ESMO 2025 updates, and the real world decision making. To formally begin with this scientific journey and set the context for today's discussion, I invite our program convener, Dr. Ankit Batra, Associate Professor, Medical Oncology, Cancer Research Institute, Himalayan Institute of Medical Sciences, Dehradun. Sir, we request you to kindly deliver the welcome address and introduction.
Yeah, thank you so much. Very warm welcome and good evening, everyone. For the next 2 days, will be having this Onco Edge webinar. In this, we'll be discussing about the updates brought up in the ASMO and whatever new drugs or trials and latest approvals have been there. So we'll just recapitulate on the latest few things in each site so that we can update ourselves and give the benefit of the this update to our patients in terms of better uh, survivals, quality of life, and how we can provide them the latest cutting edge treatment right since its approval. I thank everyone for joining and spending time in this late evening so that we can update ourselves and move forward in enriching the knowledge. And I also thank our academic partners for generously participating for the event. So with that, I welcome everyone so that in next 2 hours today and tomorrow, we can discuss the ASMO updates and whatever new updates we have got in form of various new drugs and trials. We can discuss and dissect the data to pass on this benefit to our patients. With this, I would begin with the first talk, that is the ESMO 2025 outlook in the breast cancer, and I'll discuss the few important trials which have been updated and presented in the ESMO 2025. Please allow me to share the screen. So I'll be discussing about what are the top pick trials in the breast cancer arena in the ESMO 2025, which was held in Berlin. So this was one of the very important and pivotal trials, that is Destiny Breast 05. So you can see that it was comparison of trastuzumab deruxtecan TDXT versus trastuzumab M10, that is TDM1, in patients with high risk human epidermal growth factor 2, that is HER2 positive primary breast cancer after the residual invasive disease after the neoadjuvant therapy. So we all know that we have seen the in trial and we have seen the usage of adjuvant TDM1, but what's the need of TDXT? So we still have a lot of high risk patients where we can see that we need to improve upon. So this was the background of the trial, and we see that in Catherine trial, the TDM1 significantly improved the IDFS and the OS related to the trastuzumab in HER2 positive EBC with the residual disease. So we have an update for that also, and we have seen that there is a significantly good IDFS and OS benefit. But early phase studies in heavily pretreated HER2 positive MBC have demonstrated remarkable activity of TDXT, and Destiny Breast 02 has demonstrated superiority of TDXT relative to TDM1 in second line metastatic setting. So we need to assess that whether this drug can be moved forward and upfront, and all those patients who are failing in spite of adding adjuvant TDM will be benefited with this or not. So this was the trial schema. It was a DB05 was a global trial, multicentric randomized phase 3 trial, and all those patients after the neoadjuvant chemo and HER2 directed therapy after surgery who had a residual disease, they were randomized 1:1 to TDXT and TD1 in the standard doses for 14 cycles. And the primary endpoint was IDFS and DFS, whereas various key other secondary endpoints. So this was the study status and the statistical analysis, how it was done. 1,600 patients were randomized. 80% power with the 207 IDFS events to demonstrate the statistically significant difference in the IDFS, and a 3-year IDFS rate from 83% projected in the TDM1 arm to 88.2% in the TDXT arm was thought of. And this is the population which was screened and then randomized. And the baseline characteristics, it was very well matched in terms of age. The median age was 15 both the arms. And then the region, Asian population constitute around 50% of this total population. In performance status, then very importantly the ISC 3 plus, which was 82%, and ISC 2 plus and fish positive in around 15% of the patients. And the hormone receptor status, so it was 30% around was TNBC, and hormone receptor negative, and 70% were positive. So this is the most important slide of this trial, and as you can see, at 3 years, the IDFS was significantly better. It was a delta of 8.7 was there, that is 92.4% with the TDXT versus 83% with the TDM1. So it has shown a significant benefit. And if we see the forest subgroup analysis, so it was benefiting in all the subgroups towards the use of TDXT, and uh, it was not favoring TDM1. So we can see that there were lower distant and loco-regional recurrences which were observed with TDXT versus TDM1, including the CNS recurrences. This was most important thing. The CNS recurrences was also less. If we talk about the disease-free survival at 3 years, so it was again almost close to 9% improvement, which was 92.3 versus 83.5% with the hazard ratio 0.47. So definitely, yes, it's a very good result. And once we have a longer follow-up, uh, the quantum of benefit will definitely be more, because we know that in any EBC breast setting, we need a long follow-up to demonstrate differences, especially in terms of overall survival. Then the other uh, overall, the DFRI and the BMI OS, we can see that distance recurrent-free interval was also significantly better. The BMFI was also better, and overall survival was 2.9% different at the time of maturity. However, longer follow-up are still going on. Then the study treatment exposure. So the median study duration in months was 9.8 versus 9.7 for the for the cycles. And if we see, 14 cycles were completed, close to three-fourth of the patient in both the arms. So this is important because almost close to one-fourth of the patients are having toxicity in both the arm, and they were not able to continue till 14 cycles. Safety is very important because we know that TDM1 is much smoother drug as compared to TDXT, especially in terms of toxicities like ILD and pneumonitis. So that was higher with the TDXT, and we need to select the right patient so that we can benefit the patient rather than harming them. So in terms of the side effects, the patient selection is very, very important. We need to screen whether the patient is a uh, is not a candidate who have a pulmonary toxicity. In terms of grade 3 or more side effects, so 50% in both the arms, and they were comparable. In terms of toxicity, so we know that TDXT is a highly hematogenetic drug, so nausea, vomiting, constipation, GI side effects were very high. Apart from that, most of the side effects were comparable, and majority were grade 1 and grade 2. So ILD, which is very important. So if we talk about grade uh, 2, so it was significantly higher in the TDXT. So this is one important aspect when we need to look into it before switching our practice to TDXT as a adjuvant therapy. So DB05 concluded a statistically significant and clinically meaningful improvement in the IDFS and DFS with the use of TDXT. It was benefited across all the pre-specified population, and CNS meds and death were numerically fewer in TDXT and TDM1. The overall safety profile was manageable with no new signals, what you know previously with the TDXT. But my take would be that we need to have a more longer follow-up. We cannot just switch to a drug which can cause significant ILD, pneumonitis, and other side effects, especially just on a 3-year IDFS rates. But yes, definitely it's a new upcoming option for high risk early breast cancer, which HER2 positive, who do not achieve a PACR after the neoadjuvant chemotherapy. Then the second important study, the monarchy, we already know, but there was evaluation of the prognostic and the predictive value of Ki-67 index pre and post neoadjuvant chemotherapy and how it changes following the neoadjuvant chemotherapy. So this was the trial schema in the background, and all the node positive, high risk, HR positive, HER2 negative EVC, which were randomized to Abema plus endocrine versus endocrine therapy. So we know that the IDFS benefit was regardless of the time of prior chemotherapy, and it was increasing once the follow-up increased. If we see the neoadjuvant chemotherapy patient subgroup, so here it was much better, and at 5 years it was 77 versus 65%, so a delta of 11.2, and the hazard ratio was 0.65. Then the distribution of patient by the Ki-67 pre and post NACT. So high Ki-67 uh, in all those patients which remain high, and uh, in those who it converted from high to low, and then the low Ki-67 which converted from low to high and remain low. These were the two subgroup, and Ki-6 changes after the neoadjuvant chemotherapy and post-NAC were noted. So the IDFS outcomes in patient with high and low Ki-67 pre and post NAC were different, and we can see that Ki-67 high it was 94 versus 140 events. So the difference in IDFS was significantly better. That was around 84.9 versus 74.5% as compared to the lower ones, which was 79 versus 69.2. Whereas in the post NAC, if you see that difference in the IDFS was more increasing. So if the K67 is turning out to be low to high, so the benefit of adding adjuvant was better. So these show that the prognostic effect of the changes in the Ki-67 index post-NEC are very important, and it's a very important study to note that patients whose tumor remained high Ki-67 post-NEC at the highest risk of recurrence, or those who are converting from low to high, they also have a high risk of recurrence. So this is some of the simple biomarker which we can use in our practice to select patient for adjuvant CDK4/6 inhibitors if the patient is not very keen or motivated, or there are financial issues in our kind of settings where it can be used. So this is again to show the predictive effect of the changes in the Ki-67, and it's now proven that all patients benefited from the addition of abemaciclib regardless of the change of the Ki-67 index. So high Ki-67 index pre and especially post-NAC is a prognostic factor of high risk of recurrence. Patient whose tumor retained a high Ki-67 index following NAC has the highest risk of recurrence. And the treatment benefit of Abema plus ET versus ET alone was consistent regardless of the Ki-67 index pre-NAC, post-NAC, and also Ki-67 changes. So moving forward, then we have the third study, that is the Ascent-03. Again, it was a randomized phase 3 study of sacituzumab govitecan versus chemotherapy in patients with previously untreated metastatic triple negative breast cancer who are unable to receive PD-L1 inhibitors. So the unmet need in these kind of patients previously untreated with or metastatic TNBC who are not candidates for PD-L1 inhibitors. We see that around 60% of the patients are not the candidate for PD-L1 inhibitor due to various reasons, and the median PFS in this in the first line setting is less than 6 months with chemo alone, which is the practical current standard of care. And 50% of the patient treated in the first line do not receive the second line. So it's a very grave problem. And the rationale brought by the Ascent-03 was sacituzumab govitecan is the only TROP2 directed ADC with the survival benefit in multiple phases of metastatic breast cancer. It is approved in the second line, and there are urgent need to improve therapeutic options in the earlier lines so that to delay the progression and time for the next line therapy. So this was the trial schema. All those patients who are not considered for immunotherapy-based therapy in the first line, they were randomized to sacituzumab govitecan versus the standard of care chemotherapy. And patients with previously untreated, locally advanced, inoperable, or metastatic TNBC who were not the candidates for PD-L1 inhibitor, they were again randomized to sacituzumab 10 mg per kg IV every 3 weekly, day 1 and day 8, versus the standard of care chemotherapy as per the PI. So these were the statistical analysis, and the baseline characteristics and the demographics were very well matched. Nothing specific to discuss in this. Yes, so this is the progression-free survival, and if you can see that for the 6 months it was 65 versus 53%, and 12 months PFS was 41 versus 24%. And if we talk about the median PFS, it was 6.9 months with the chemotherapy versus 9.7. So it was statistically significant, but practically sacituzumab govitecan is not easily accessible in terms of logistics for all our patients. So definitely it's a good upcoming options, but we need to wait for the accessibility to a larger population domain, and it brings down 38% reduction in the risk of disease or progression. So this was the subgroup analysis forest plot. Again, it was benefiting toward the use of sacituzumab govitecan in most of the subgroups. This was the tumor response, and the duration of response was also significantly better. That is 12.2 months as compared to 7.2 for the chemotherapy. Then we have the overall survival in the PFS2. So overall survival was not yet matured. It was still on the follow-up. And PFS2 was better 14 months with the chemotherapy versus 18.2 with the SG arm. So at the time of primary analysis, the OS was immature and PFS2 was longer with SG as compared to the chemotherapy. In terms of safety, it's a tolerable good drug. And if we talk about grade 3 or more side effects, so it was similar as compared to we see with chemotherapy. And mainly the side effects were marrow suppression, nausea, vomiting, diarrhea, fatigue, what we usually see with the most of the ADC and the chemotherapy drugs. And majority were grade 1 and grade 2, except for neutropenia, which was seen in 43% of the patient, which was grade 3. So we need to observe the neutropenia and be wary of the febrile neutropenia. So they Ascent-03 concluded that SG led to a statistically significant and clinically meaningful improvement in the PFS, almost close to 3 months. And overall response rate was similar between the two groups. OS was immature. Toxicity-wise, well tolerated, but because a lot of neutropenia was there, so prophylactic GCSF used as advice, and treatment discontinuation were lesser with the SG group as compared to the chemotherapy. Then this last trial, that is the first line Dato-DXd versus chemotherapy in patients with locally recurrent, inoperable or metastatic triple negative breast cancer for whom immunotherapy was not an option. So for all those patients where immunotherapy is not an option because of various reasons, so here Dato-DXd can be an important drug because we know that TNBC is aggressive cancer subtype, and the 5-year overall survival in metastatic TNBC is very, very dismal. In majority of the cases, immunotherapy is not a feasible option or best option in the first line. And Propion Breast 2 was designed to determine whether first line Dato-DXd can improve clinical outcomes. So it's another ADC which has been tried. And again, these kind of patients were randomized 1:1 to Dato-DXd 6 mg per kg IV day 1 every 3 weeks. And then compared to the investigator choice chemotherapy. So the primary endpoint was overall survival and PFS with various key other secondary endpoints. This was the statistical method what they have used. The demographics and the baseline characteristics were very well matched, and so this was the progression-free survival. So the PFS curve for Dato-DXd versus chemotherapy, if we see at 18 months, it was almost double, 16% versus 32%, with a hazard ratio of 0.57. So the doubling of PFS has been seen with the use of Dato-DXd, and it was statistically significant and clinically very meaningful. This was again the PFS by the investigator, and here it was much, much better. That is at 18 months, 9 versus 27%, so almost 3 times with a hazard ratio of 0.56. Then it's also demonstrated a overall survival benefit and close to 51 versus 61% overall survival at 18 months rate. The median OS was 23.7 months versus 18.7 months, and a delta of 5 months was seen. So Dato-DXd demonstrated significantly and statistically significant and clinically meaningful OS benefit and led to a 21% decrease in the risk of death. This was the subgroup analysis for the PFS. The forest plot shows that it is favoring the use of Dato-DXd for all the subgroups, including the AH, RAS, performance status, PDL1 status as well. and it was benefiting more the patients with CPS less than 10 as compared to more than 10. And the visceral meds did not dictate any favorism. And this was the subgroup analysis forest plot for the overall survival. So it also benefited the use and towards favors toward Dato DXD. And the overall safety summary. So if we see grade 3 or more than grade 3 side effects, so it was comparable in both the arm, 33% in the Dato DXD versus 29%. And dose interruptions were also close to similar. Then dose discontinuations were similar. They were not different in both the groups. And the median total duration of Dato-DXT was 8.7 months as compared to chemotherapy, which was just 4.1 months. And patient with total exposure more than 12 months, almost 35% patient have been able to continue treatment for more than a year as compared to chemotherapy, which was just less than 10%. So, despite more than double the median duration of treatment for Dato-DXT, rates of grade 3 or more than grade 3 serious side effects and the other treatment-related AE were comparable and were lower with the Dato-DXT as compared to the investigator choice chemotherapy. The most common treatment-related adverse event, if we talk more than 15%, so specifically grade 3 or more, so it was dryness of the eyes in 1%, stomatitis and nausea, then followed by other GI side effects, and neutropenia anemia in 1 to 2%. So it seems to be a very uh, easily tolerable drug as compared to the other ADCs which we have seen and used previously. And if we talk about the treatment-related adverse events for Dato-DXT, then mucositis, stomatitis are seen in around 8 to 10% of the patient. Ocular surface events, that is dry eye, keratitis, and conjunctivitis, should be looked forward. And if we talked about ILD or pneumonitis, so it is very, very less, less than 1% in grade 3 or more. So it's a very seems to be, although I have not used, but seems to be with this data, a very easy to drug as compared to the other ADCs, because we know that ADC, the chemo moiety is significantly higher, and we see a lot of specific and high numbers of toxicities. So that is not seen in Dato DXD. If we talk about response, so overall response rate, it's almost double, 29% versus 65%. And with Dato DXT, confirmed overall response was more than double as compared to the chemotherapy. Duration of response was also better, and the median duration of response was 12.3 months versus 7.1. So that was also significantly better. The median duration of response was more than 1 year with the Dato DXT. Then this ORR subgroup analysis, it is also favoring the use of Dato DXT clearly. So the Tropion Breast 02 met both the dual primary endpoints with the first line Dato DXT, which was statistically significant in terms of OS and the PFS over the investigator choice chemotherapy, and more than 5 month improvement in both the median PFS and OS was seen. As I told, that the safety profile was manageable and consistent with the known profile. So despite more than double the median duration of treatment, rates of grade 3 or more serious adverse events were similar, and discontinuation rates were lower. And these kind of patients were the representation of the real world TNBC population, including those often excluded from the clinical trials. So, Tropion Breast 02 results support the use of Dato DXT as the first line standard of care for the patients with locally recurrent, inoperable metastatic TNBC, where immunotherapy is not an option. So with that, thank you everyone for your patience listening. Would be happy if someone wants to add anything or wants to give any comments or any question.
Thank you, Dr. Batra, for that comprehensive and clinically relevant overview. Our next talk addresses the role of Tecentriq in first-line patients with advanced NSCLC not eligible for a platinum-containing regimen. I am pleased to invite Dr. Suhail Qureshi, Director and Unit Head, Medical Oncology, Fortis Hospital, Delhi. Dr. Qureshi, we look forward to your insights. There's also a small request to all the speakers. Kindly keep your videos on during your respective sessions. Thank you.
evening, and thank you to the organizers, and thank you to Dr. Ankit for this opportunity. I hope I'm audible and
So
my
you are
screen
audible,
is
but your voice is slightly feeble.
uh, is my screen visible? Is my voice better now?
Not so.
So let me just take out my
It's better now,
AirPods
sir.
and keep it being better now.
Yeah, it's better now, sir.
Okay, so thank you to the organizers, and I hope my slides are visible. And thank you, Dr. Ankit, for this wonderful opportunity to discuss some relevant data. And this is something of a learning for my own sake as well. And often we've wondered about our patients who are elderly and frail as to what treatment options we can offer them for advanced non-small cell lung carcinoma. And this is a study which evaluated the role of Tecentriq in first-line therapy for patients with advanced non-small cell lung carcinoma who are not eligible for a platinum-containing regimen. So, just a brief overview of the epidemiology. We know that lung cancer is the fourth most common cancer in India, and it follows suit after breast cancer, head and neck or oral cavity cancer, and cervix cancer. It's the fourth most common cancer. Amongst the lung cancer histologies, non-small cell accounts for 85% of all the lung cancers, and majority of these are diagnosed at a rather advanced stage in India. And these are some really horrifying numbers, almost 81,000 new cases every year of lung cancer in India and 75,000 deaths. So that is a huge contribution to the mortality in this particular subset of patients. But what we find difficult to deal is the fact that many patients are diagnosed who are diagnosed with lung cancer are considered unsuitable for a standard platinum doublet chemotherapy, and therefore there remains an unmet need for newer treatment options for these patients who are unsuitable for this standard therapy. In the real world scenario, more than 40% of the patients who are diagnosed with lung cancer would have a performance status of 2 or more. And these are the very patients who are excluded from most of the phase 3 immunotherapy trials. And therefore, we do not really know what exactly is the correct way of treating them, primarily because the trials have always included a fit section of patients, and these patients who are PS2 or more will historically have a poorer survival than those who are rather fit. Not only that, in India, we have patients who present to us at an average age of 63 years, and therefore we need to look at this particular group of patients rather closely, so that not just that the comorbidities and the contraindications of chemotherapy sometimes make us wonder whether at all we could do something less toxic and easily manageable for this subset of patients who cannot take platinum doublet chemotherapy. So these are the various parameters or the various factors that we take into account when we are judging patients for suitability for immunotherapy, not just the histology, but the PDL1 expression, the performance status being the center point. Along with that, we also take into account the various fitness parameters with respect to the cardiac health, the renal health, the neuro and the pulmonary function, and so on. But rarely certain standalone criteria like extremes of age and a very poor performance status are considered as one important factors. But in a majority of these patients, we find that there is a combination of these comorbidities which preclude our decision for or against a doublet platinum based chemotherapy. So we have to take a decision based on patient to patient. Now, these are the current NCCN guidelines for NSCLC for first line treatment of patients with advanced NSCLC and performance status of 2 or more. So here, if I point my arrow, this is the guideline for patients with performance status of 2 or more. And this is the guidelines for elderly patients with advanced NSCLC. And you would see that although they have, sorry, although they have advised for a platinum based doublet, preferably carboplatin, in eligible patients with PS2. But when it comes to patients who are worse than PS2, it says that there is insufficient data for the use of monotherapy immune checkpoint inhibitors, or for that matter, single agent chemotherapy like gemcitabine or docetaxel or pemetrexed, as the case may be based on histology, as the recommendation for these patients. Patients with performance status of 3 or 4 should be offered best supportive care. Very similar guidelines for elderly patients. You must weigh the toxicity of a platinum doublet and should discuss with them. Carboplatin monotherapy is the preferred option when the toxicity is deemed tolerable. And again, for patients not eligible for a doublet chemo, single agent chemotherapy remains the standard of care. On the right side of the screen, you would find this is an Italian study called the Moon OSS trial, which looked at treatment patterns for advanced NSCLC in patients who were considered unfit for standard platinum-based chemo. And the main reasons to avoid platinum-based regimens were advanced age of more than 70 years, comorbidities, and a performance status of 2 or worse than that, and family or social issues. And in a large majority of cases, a multitude or a combination of these factors contributed to guide the treatment decisions. So just like we have in urothelial carcinoma, we have a Galsky criteria which guides us regarding platinum suitability. We don't have that kind of a set criteria for determining which patients are unfit for treatment with doublet of platinum. But then we can see that patients who have age of more than 75 years are considered unfit for cisplatin, and if they are more than 80 years, they are considered unfit for carboplatin. As far as PS is concerned, patients with a PS more than 1 would be considered slightly unfit for cisplatin, and PS2 or worse would be unfit for even carboplatin. Renal function, the creatinine clearance less than 60 would preclude the use of cisplatin, and if it is less than 45, then even carboplatin goes out of the picture. And then there are other risk factors that we often weigh on a case-to-case basis. So what do we do in those situations? So this is a snapshot of randomized first-line single-agent chemotherapy trials. And most of these studies are the pre-immunotherapy era, where patients were deemed unsuitable for platinum-based chemotherapy, and single-agent chemotherapy using gemcitabine or vinorelbine or docetaxel and pemetrexed were used in different situations. Only one of these studies is from 2021, where immunotherapy was already being used, but the other studies are the pre-immunotherapy era. So before the advent of immunotherapy, it may be highlighted that only single agent chemotherapy was the way to go. And even then, patients more than 70 or more than 65 or with a performance status of 2 or more, it was very difficult to subject them to even chemotherapy with that kind of comorbidities. And the best case scenario for these patients was a median OS of ranging from 4.7 months to something like 9 months. So basically, there are no randomized phase 3. When it comes to immunotherapy, we know that we just like trying to highlight the evidence for single agent immunotherapy in these frail patients. And the evidence is scarce. There are no randomized phase 3 trials investigating first-line pembrolizumab in patients with a poor PS or platinum ineligibility. The Pepsi-2 study was a study in NSCLC patients of performance status 2 or more. It was a single-arm phase 2 study, enrolled only 60 patients, of which 24 patients were first-line. The median OS was 7.9 months in first-line patients, and the PFS was 4.3. So not really remarkable numbers there. The investigators have also tried a combination of Nivo plus EP in a phase 3 study for first-line NSCLC metastatic with PS2 or more and older patients of 70 years or older. This study basically was halted because of high mortality rate and a median OS of 2.9 months. A similar study with durvalumab in patients with ECOG PS of 2 or more and a PDL of TPS of 25% again resulted in an unexpectedly higher number of fatal events, and the patients were stopped for enrollment. So these three immunotherapy strategies, which is pembrolizumab, a Nivo EP combination, or durvalumab, have also failed to benefit these high-risk patients who are either too old or too frail to take immunotherapy. There comes the Ipsos study to the rescue. So Ipsos was a phase 3 global multi-center open label randomized study. Indian patients were a part of this, which randomized patients between atezolizumab versus single agent chemotherapy of investigator's choice in patients who are considered unsuitable for first line platinum based doublet chemotherapy. So, what is the background for this study? We know that the pivotal trials of immunotherapy first line treatment with or without chemo has improved the OS versus platinum doublet. However, these studies and most treatment recommendations are limited to patients with a good performance status or who are rather young. In the real world setting, 40% or more of the patients of NSCLC have poor PS of ECOG 2 or more and are elderly with multiple comorbidities, precluding the use of doublet chemo or sometimes even immunotherapy. So, given this relatively poor prognosis and limited treatment options, when compared with the giant strides that we have taken in other areas, for patients who are either good performance status or oncogenic driven gene cancers, this population is rather underrepresented in trials, and therefore there's an unmet need to examine the efficacy, safety, and quality of life issues with novel therapeutic options, which is monotherapy with immunotherapy like Ipsos. So this was the study schema. It was enrolling straight treatment naive stage 3B and 4 NSCLC patients with squamous or non-squamous histology. They were platinum ineligible either because of poor PS or because of age being more than 70. Uh, EGFR or ALK positive patients were excluded, and patients with treated asymptomatic brain mets were permitted to be a part of the study. 450 patients randomized in a 2:1 fashion between atezolizumab 1200 milligram every 3 weeks versus chemotherapy of investigator's choice, which was either vinorelbine or gemcitabine. Both of these given until progression of disease or loss of clinical efficacy. And the primary endpoint was overall survival, with secondary endpoint being PFS, objective response rates, and duration of response. It was also stratification factors between PDL1 expression, histology of squamous versus non-squamous, and presence or absence of brain metastasis. So the baseline demographics were reasonably well matched between the two arms. What is important to remember here is that if you would see my arrow here, that around 32% of the patients, 1 out of every 3 patients in the atezolizumab arm was more than 80 years old. Between 70 to 79, 41% patients. So if I would say that this study included patients, 75%, almost 75% of these patients were more than 70 years of age. PS2 patients were predominantly 75% in this study. Apart from that, the non-squamous were 57% and squamous 43%, and they were also well matched between the two arms. 9% patients had brain metastasis, 15 to 16% patients had liver metastasis. PDL1 expression, almost 17% patients had a TC score of more than 50%, but less than 50% was 75% in the atezolizumab arm and 76% in the chemotherapy arm. So reasonably well balanced demographic criteria between the two arms. So this was the primary endpoint of overall survival. As you can see that these two curves are neck and neck till about 4 months, and then the curve starts separating out. And as is evident with most immunotherapy trials, that it is the tail of the trial that eventually drives the benefit. The median OS is a benefit of just about 1 month between the chemo and the atezo, 9.2 versus 10.3 months, with a hazard ratio of 0.78. But if I were to draw your attention to 24 months OS, then it is 12.4% versus 24%. So a doubling of OS, again indicating that the tail of the curve is what is driving the benefit in the survivors. And till now, we have a median follow-up of 14 months, and this benefit is actually clinically significant. When it comes to the forest plot, then all the subgroups showed that the benefit was consistent in favor of atezolizumab across the key subgroups, whether it was age, whether it was gender, whether it was histology. All of the evidence was tilted towards the atezolizumab arm. The PDL1 expression as well, whether it was less than 1% or it was more than 1%, everyone seems to be benefiting in favor of the atezolizumab as compared to single agent chemotherapy. So that's that's a very welcome pattern that we are seeing over here. This is the progression-free survival. Again, these curves are neck and neck, and not much of a difference between median progression-free survival, 4 and 4.2 months. But again, it is the curved tail which is driving the difference. And at 24 months, look at that PFS difference. The delta has actually gone up to more than 7.5%. 1.6% PFS at 24 months in the chemo arm, and 8.9% in the atezolizumab arm. As far as objective response rates are concerned, almost double the responses in atezolizumab, 16.9 versus 8%, with even 1.3% of the patients having complete responses with immunotherapy atezolizumab, and around 15.6 partial responses, and no complete responses with chemo, and around 7.9% partial responses. So again, a doubling of the overall response rate as well as the disease control rate. When it comes to the quality of life parameters, then this was a patient-reported outcomes with functionality scales. Again, shows that the atezolizumab arm remained stable with less than 10% variation across all domains, while the chemotherapy arm showed some deterioration as the study progressed. Similar features over there, an improvement in atezolizumab arm and deterioration in the chemotherapy arm with respect to different parameters like cough or peripheral neuropathy, or for that matter, chest pain. All of these were definitely better in the atezolizumab arm. Time to confirmed deterioration was also longer. That means the depth of response and the duration and the durability of this response was rather sustained with the single agent atezolizumab versus immunotherapy. And this is the summary of adverse events. And if I were to draw your attention, then the atezolizumab arm, the median treatment duration was around 3.5 months, which was around 2.3 and 1.8 months with respect to the chemotherapy. The treatment-related adverse events, 57% in the immunotherapy atezo arm versus 80% in the chemotherapy arm. Grade 3 or 4 adverse events, 16% versus 30%. Again, immunotherapy doing remarkably well over there. Serious adverse events, 11% with the atezo arm and 15% in the immunotherapy arm. Now, what you see here in the light blue column is the monotherapy historical data of atezolizumab from the previously conducted studies of atezolizumab, and they have compared this with this study done in elderly or frail patients. No differences in the observation of various immune-mediated adverse events or any adverse event of special interest. So you could see that immune-mediated rash 19% historically versus 15% in this study. Immune-mediated hypothyroidism, which we see very commonly, 5% or 9% in this study, historically 5%. Immune-mediated hepatitis, 2 versus 2.3%. So what I'm trying to highlight is that no new safety signals were observed even in this elderly group of patients who were performance status 2 or more. So basically, this is a new therapy which is empowering the patients who have been deemed ineligible for doublet chemotherapy or a single agent chemotherapy, not really helping their cause. In this study, 76% of patients were performance status 2 or more. These patients, monotherapy is also a good option for those patients who have reduced renal function. So they are not eligible for cisplatin or sometimes even carboplatin. Because of advanced age, many of these patients do not get the best therapy, and therefore this is a good option for patients who are elderly and who would have otherwise been considered too frail for standard chemo. And not only that, but the number of comorbidities that these patients were suffering from was average of 6. So this is a therapeutic option for those patients who have a lot of comorbidities, and this also reduces the risk of treatment-related complications, as we have seen with comparison of the historical data of monotherapy. So now NCCN guidelines recommends that this Ipsos regimen of atezolizumab monotherapy and is an option for PS3 patients regardless of PD-L1 expression, which is also endorsed by the ESMO guidelines. Recently, for patients with metastatic NSCLC, that atezolizumab monotherapy can be considered for patients ineligible for platinum-based chemotherapy due to either a performance status 2 or more, or age being 70 years or more, or with comorbidities regardless of PD-L1 status. So this is now being endorsed by major guidelines across the world. So these are my conclusions after highlighting this important study, that first-line atezolizumab significantly improved OS over third-generation single-agent chemotherapy in patients with NSCLC deemed ineligible to receive a platinum doublet. This benefit was consistent across key subgroups. The two-year OS rate was nearly doubled with atezolizumab, 24 versus 12%. The objective responses were doubled with atezolizumab, with more durable responses of 14 versus 7.8 months. The health related quality of life showed that patients did not report any new safety or quality of life affecting concerns. And this was a rather safe therapy in this high risk group of patients. There were no new safety signals. Treatment related grade 3 adverse events or serious adverse events occurred in a small proportion of patients receiving atezo monotherapy versus chemo. And these were in consonance with the historical data of atezolizumab studies that we have seen in the past. And there were no new or unexpected safety signals identified with atezolizumab. And therefore, Ipsos is the first randomized phase 3 study of immunotherapy to show that first line treatment with atezolizumab improves overall survival, the holy grail in oncology, in this poor prognosis NSCLC population who have no EGFR or ALK or any oncogenic driven gene alterations, with no new safety signals and still maintaining the quality of life. Thank you very much for your patient hearing.
Thank you so much, sir.
Thank you,
It
Dr.
was,
Qureshi,
yeah,
for
thank you
clearly
so much, sir.
addressing and I'm sorry.
Yeah, thank you so much, sir. It was indeed one of the trials which we need for practically for most of our elderly patients. So, do you see any concern adding chemotherapy once the patient has been started on immunotherapy and the PS has improved after 1 or 2 cycles? So, would you like to do that, or you will just stick to the trial? Is there any added advantage or benefit of that if you can put?
So that's a very inviting strategy, Dr. Ankit. I mean, we all would, it reminds me of that slogan, "Ye dil mange more." So we never settle at the benefits that we get. So yes, practically speaking, I would say that I would begin with single agent immunotherapy, atezolizumab in that case, and I would see whether the patient's performance status improves, and it allows me to add something, maybe a single agent carboplatin or maybe a paclitaxel, as the case may be. I might be tempted to add that once the patient has achieved, in my view, the ability to tolerate that. But then there's a flip side to it as well, that if the patient is already doing well with one therapy, then sometimes adding another chemotherapy sometimes can be deleterious, and the benefits that you have accrued till then may get lost because of the chemotherapy toxicity. So I think it's something that needs to be discussed patient to patient, and you really cannot have a blanket statement saying that this is the strategy I would use. I think I would discuss with the patient and customize the therapy rather than have a one size fits all approach.
Yeah, agreed, sir. So that was just a thought whether adding something in terms of chemotherapy later after 2 or 3 cycles would help or harm, we don't know. And it can help in some patient and harm in some. So I think we are not going to get any kind of study in that area. But definitely thing to be discussed with patient. And yes, I agree that it should be individualized with patient to patient. Yeah. Thank you. Thank you so much, sir.
Thanks a lot. Thank you very much.
So moving on to gynecologic oncology, I invite Dr. Suman Karant, Additional Director, Medical Oncology, Fortis Hospital, Gurgaon. Welcome.
Hi, thank you so much. Hello,
Yes, ma'am, you're audible.
I'm audible, right? Yeah, okay. Thank you so much, Dr. Ankit, for having me here in the conference. I am having some issues with my camera. I'm turning it on, but the video isn't actually turning on. So apologies for that. I'll share my slides now. Are my slides visible?
Yes,
Yes,
ma'am,
ma'am,
it's
it's
visible.
visible.
Yeah, okay. Good evening, everybody, and thank you, Dr. Ankit, for having me here. And thank you to all the organizers. So I'll be discussing the management of first-line ovarian cancer. And I think there has been a lot of advancements in this space. I think gynecological oncology is probably going to be the new lung in the future. Lots of things coming up in this space. Uh, this is my disclaimer. for the meeting today. Now, advanced ovarian cancer is actually one of the leading causes of death in women. And this is despite aggressive surgical resection or a standard, first-line platinum-based chemotherapy. The 5-year overall survivals of ovarian cancer continues to be dismal at 50.9%. And for advanced stages, the things that can be even worse. And this is because we know that 70% of the women with advanced ovarian cancer actually relapse in the first 3 years. And this is if you do not have any sort of first-line maintenance therapy. So the landscape of ovarian cancer has changed dramatically in the last few years, and there's been a lot of advancements. First came, first we had just Paclitaxel, then we had Bev as maintenance, then it became, a flurry of PARP inhibitors, and then, combination of PARP inhibitors, then, newer therapies that are coming up as well. So a lot of changes have happened in terms of survival. Just 1 minute. So this is actually a very nice slide of how the PARP, inhibitors, how they are depending on the biomarkers in different subgroups. So, for example, if you have a BRCA mutant patient, and this is germline BRCA, then you have olaparib, which is applicable. This is only for germline BRCA, though I think in practice people use it across HRD positivity as well. For HRD, actually, and when I say HRD, it means BRCA mutant and HRD BRCA wild type. It is olaparib plus Bev, so you have to add Bev as well to it. Now, for example, you have all the rest of the population. You can see this now. The green is the niraparib and the yellow is the rucaparib. So all across the population, and we know 50% are HRD wild type. These two drugs, that is niraparib and rucaparib, are applicable to be used. These are the clinical guidelines for maintenance therapy for patients with advanced ovarian cancer. In ASCO, the American guidelines, a newly diagnosed stage 3, stage 4 advanced ovarian cancer in a CR or a PR, you can give this after first-line platinum-based chemotherapy, and 2 years is for olaparib and rucaparib, and it is 3 years for niraparib. This is the option for germline and somatic BRCA. Now, rucaparib and niraparib, like I said, is for a positive HRD testing as well. If Bev was used in the first line, you can offer it along with olaparib in the germline or somatic BRCA mutant patients. And niraparib and rucaparib should be offered again for anybody who's HRD negative. More or less similar is the ESMO guidelines as well. But probably in the front line, in patients with newly diagnosed ovarian and CR and PR, they do offer olaparib here, 3 or niraparib or ola plus Bev over here. So they don't actually talk about rucaparib here in these guidelines. So the real world part for inhibitor monotherapy maintenance actually extends progression-free survival versus active surveillance. This is the orange curve, which is where you have PARP inhibitors being used as a monotherapy, and the blue one is actually where you're just doing active surveillance. And you can see there is a big difference in survival. And here in active surveillance, these patients actually received in the second line. So in the real world, actually, only 56% of first-line patients are, the ones who are actually eligible to receive PARP, only 56% of them are actually on maintenance therapy. A lot of people are only on active surveillance or just on bevacizumab. So this is the pie. This is the small little pie, which is actually patients who are eligible and they're actually receiving therapy. So this is again data from US. So you can see if US is like this, what's happening in India as well. So there is a big bench to bedside. There is a lot of disparity despite of the data happening. Whenever we consider treatment of a patient in first line, the first line journey, you have to look into a lot of factors. Whenever it is an advanced disease, the first and foremost is the platinum response. How are they platinum sensitive or not? What is their accessibility to therapy? How are you genomically profiling these patients? What is the stage of disease? Again, in advanced stages, Is there residual disease post-surgery? Or what was the outcome of surgery? What timing did you do the surgery? Did you do it as a primary debulking or an interval debulking? What is the histology? We know certain histologies are very bad. How did you administer the medications and what are the comorbidities? So a lot of things play a very significant role in the outcome of patients. So how do we actually most effectively decide first line therapies? So in whenever you have an HRD positive disease, BRCA mutant, you do chemotherapy, then you do PARP monotherapy for oral for either 2 or 3 years. 3 years if you're giving niraparib. If you have done chemo plus bev, you add PARP plus bev as maintenance, oral for 2 years, IV for 15 months. If you have a BRCA wild type and you have given chemotherapy, do PARP monotherapy alone, oral for 2 years or 3 years, depending on which you have selected. If you have done chemo plus bev, continue that combination. This is for HRD positive disease, BRCA mutant versus BRCA wild type. So they're more or less very similar in their recommendations. Now, what would you do for a non-HRD positive patient? If you have a complete response or a partial response to platinum, you can consider PARP monotherapy. But if you have no response to platinum, we do consider that platinum response is actually, it does guide you with PARP therapies. If you do not have any response to platinum, especially in the high-risk disease, it is better to stick to bevacizumab for 15 months. So we look a little bit about the pharmacokinetics of niraparib. Niraparib is associated with its effectiveness all throughout in the ovarian cancer, whether it is an HRD positive or an HRD negative proficient tumor. It is highly potent. It is a selective inhibitor of PARP1 and PARP2, and its potency is almost twice as that of olaparib and rucaparib in terms of trapping the PARP. So we know it is more effective. It achieves a very high drug concentration and it delivers a sustained PARP inhibition is what we require, and that translates into a sustained response. So it helps actually inhibit tumor growth in both the mutant patients and wild type, and even in the proficient population as well. So we'll look a little about the PRIMA trial. PRIMA trial is actually the trial that brought in the data for niraparib in first-line advanced ovarian cancer. This was a randomized phase 3 double-blind placebo-controlled trial where they looked into niraparib as a maintenance therapy. These were newly diagnosed patients, randomized 2:1 for niraparib versus placebo, and it is 3 years here. So as opposed to the others, which are 2 years. The main endpoint was PFS. What I want to highlight here is complete and partial response. Both patients were included. Neoadjuvant setting, whether neoadjuvant chemo was delivered or not, was taken into account. In the stage 3 populations that they had, anybody who had a stage 3 primary debulking surgery, if they had residual disease, they were actually included in this trial. So this trial actually had high-risk population. Now, one of the inclusion criteria also was post-therapy, post-platinum-based therapy. If the CA125 has to be either in the normal range or there has to be at least a decrease of more than 90% after frontline therapy, and this has to be at least stable for more than or equal to 7 days. So no primary progressors were allowed in the study. Here in the study, 2/3 of the patients received NACD. That means that they were high risk, obviously high risk disease. And if you look at this PR was actually in 30.8%. More than 99% of the stage 3 disease had some visible residual disease after PCS. So these are high-risk population patients which they included in the study. Biochemically, the criteria I've already mentioned. And when they looked into the classification, HRD mutant, HRD deficient BRCA mutant was about 30%, and 20.5% was the wild type population. So if you look at here the curves, the intention to treat population, clear benefit of niraparib. 5-year PFS was 22% versus 12% in the placebo group. 13.8 months of PFS versus 8.2. Now coming to the HRD deficient population, here you can see that the curves actually separate more and more. At 5 years, it is 35% PFS rate versus 16%. 24.5 months PFS versus 11.2, and a hazard ratio of 0.51. Now, coming to the HR proficient population, this is actually the population we are most worried about because this is an unmet need, definitely. So here, the 5-year overall survival, you can see it's a PFS, sorry, is 8% versus 7%. 8.4 months was the median PFS in niraparib versus 5.4 in the placebo group. You can see that these hazard ratios are still very significant. There is a clear-cut benefit in adding niraparib all across the population, definitely more in the HRD deficient population. The quality of life was actually well maintained across both the arms. The overall survival now here, I'll talk about it in subsequent slides. Here you can see that the overall survival analysis did not show any difference between treatment arms in the intention to treat population, HRD and HRR population. You can see that they're almost merging. But again, there are explanations for this. I will come to it in the subsequent slide. In the niraparib group, the median overall survival was 47 months in the intention to treat population. 72 months for the HRD deficient population and 37 months for the HR proficient population. And this is despite the high risk characteristics. So this is something to remember. What is the most important point is that PRIMA demonstrated almost a threefold higher and early post-progression PARP use in patients who were randomized to the placebo versus that of niraparib. So whenever we talk about OS, we talk about what subsequent treatment did the patient receive. So you can see that out of these people who had a placebo, especially the HRD deficient population, they had almost a 57% usage of the subsequent niraparib use, and more of those who received subsequent PARP inhibitors, more than or equal to 90% actually 80% received it in the second line setting. So you can see this is the amount of subsequent PARP inhibitor use in the second line setting. When they looked into the long-term safety, there was a consistent safety across 7 years of the follow-up. And, we are familiar with the side effects. Of course, the side effects are slightly more in the PARP arm, but this is what it is with almost all PARPs. Nothing that was unmanageable. And the key takeaways from the PRIMA trial was that it was a positive study. It did meet its primary endpoints while evaluating it as a first-line maintenance therapy in high-risk population. It demonstrated a sustained PFS at 5 years. The final overall survival did not show any difference between the treatment arms in ITT and HRE population, but this is because of majority of the patients in the placebo actually subsequently receiving, and 80% of them receiving PARP inhibitor in the second line setting. Final PRIMA analysis actually confirms a sustained and long-term efficacy and safety profile. Now, whenever we have a clinical trial, we have to actually look at the context of the data. There are several factors that impact an interpretation. What is the post-progression survival? The longer the post-progression survival, the magnitude that we have to demonstrate the benefit becomes bigger and bigger. So when you need a huge population to actually demonstrate a benefit. Crossover of PARP in a control arm. This is, as you can see in the trial, a lot of them actually crossed over. So that will impact the overall survival. Subsequent, what are the lines of treatment and the patient characteristics? How, if you've taken a high-risk population, you're actually, equalizing the overall survival between both the arms. So, for example, if the post-progression survival increases, it becomes very difficult for us to actually demonstrate a power for the study. To have a bigger power, to have a statistical sufficient power, you need to have a bigger sample size to show the OS benefit. It is still, and this is actually it's very symmetrical to the post-progression survivals. Shorter the post-progression survivals, it's actually very easy to demonstrate an OS benefit. Again, in PRIMA, the post-progression survival exceeded almost 32 months in the overall population. And you can see there has been all the arms actually had subsequent therapies. Some of them received subsequent PARP inhibitors, some of them had subsequent PARP inhibitors and chemotherapy. So Longer post-progression time, the patient heterogeneity, and the post-progression treatments, they always dilute the OS between arms. So it is very difficult to say, but it is very clear if you look at it. HRD population, the PFS in a placebo 11.2, PFS in niraparib 24.5, proficient population, PFS 5.4 in placebo, PFS in the niraparib arm 8.4. Overall ITT population, placebo 8.2 PFS, and in the niraparib 13.8. Clearly, it is much better. The overall survival is much better. The overall survival, if you had taken away the progression therapies, it would have been much better. Most of the except for PARP inhibitors, I think most of the subsequent treatments were more or less similar. There was a lot of PARP usage in the placebo arm at subsequent progression. Another thing I want to highlight in the PRIMA study is the high-risk population, the risk factors that are associated with overall survival. Age is a very important factor. ECOG-PS, disease status at diagnosis, BRCA mutation status, surgery, and residual disease. Obviously, the more the number of factors, you can see here, the more the number of factors, the survival actually gets worse and worse. So if you have no high risk, it is 87.8 months of overall survival. Now you come to 4 risk factors, it is 18.5 months. So it is not it is a very heterogeneous population. There are a lot of factors that determine the survival of a patient. Now, PRIMA study also included very high risk population as compared to other PARP inhibitors. And this is a very good summary slide of it. If you look at it, they had more number of stage 4 diseases at diagnosis. They had many NACTs, interval debulkings, visible disease after surgery, and they had BRCA wild type, and they had partial responses to chemotherapy. This is the spectrum of high-risk population that was included in this trial. If you look at the red boxes are actually high risk. You look at the green boxes here, these are actually low risk. You can see that from below the solo one all the way up to PRIMA, you can see that the population is actually getting higher and higher risk. So there is more visible disease, there is more stage 4 disease, there is more neoadjuvant therapy, and there is more PR to chemotherapy, and there are more population of BRCA wild type. All this actually makes it harder for the drug to work to actually provide a survival. So that's what I'm trying to highlight. You're getting these kind of responses in the kind of population that you had. And there was another trial, which is PRIME. PRIME showed a 3 times longer survival median PFS with niraparib versus placebo as compared to the PRIMA trial. What was different between the two trials? Why did PRIME show 24.8 months versus this is ITT versus PRIMA only 13.8? That's because, again, PRIME had a very easy, very low risk population. I mean, not a low risk, but definitely lower risk than PRIMA. They had lesser number of stage 4s. They had lesser number of PRs. They had more CRs in their population. So definitely, that, and 71% of their patients were actually stage 3. So that made a difference of why they had a longer PFS. And again, this is a similar, this one, the PFS in the PRIMA-like and the stage 3 PDS, you can see the survival differences. A better cohort will have 25.2 months versus the PRIMA-like cohort is just 10.1 months. So residual disease obviously has a poorer survival, we know that. And again, similar, there are other trials also that demonstrate that if you don't have a residual disease after surgery, definitely niraparib has a better response. So this is the summary. PARP maintenance actually has shifted the paradigm of care, and it is complex. It is not just one or two things. There are multiple factors that determine how patient responds and what are their overall survival. It is not just one or two things, but there's real world evidence, there's PRIMA, there's PRIME trial, and there are other trials as well that demonstrate this is quite a safe drug to use. With that, I'd like to end my talk. Thank you so much to the organizers.
Thank you so much, ma'am.
Thank you, ma'am, for that insightful overview. To
I just
discuss the
wanted to know
updates,
what
hello.
was your clinical experience in especially the HRD proficient subgroup.
Dr. Ankit, I missed half of your question.
Yeah, I just wanted to know your especially
Dr. Ankit, your voice
HRD
is
proficient. Am I audible now, ma'am?
not very clearly.
Yeah, I just wanted to know about your population?
I think I'm Dr. Suhail here. I think what Dr. Ankit wishes to ask is your experience for the HR homologous recombination proficient subgroup, because even in Prima, the quantum of benefit was very modest. I mean, 5.4 months versus
Yeah.
8 months. So just two and a
Yeah.
half months of benefit in the HR proficient. Although, yes, it was the intention to treat was positive, and but the maximum benefit was driven by the BRCA mutated patients and the HRD positive patients, where it was almost double, 10.9 months versus 22 months. But in
Yes.
the HR proficient subgroup, the benefit was rather modest. So maybe what he was asking is, what is your experience in the HR proficient subgroup of patients?
See, HR proficient subgroup, you'll have to always have when you explain about giving a PARP inhibitor, there's always a caveat saying this is the benefit versus these are the side effect profiles. We know it is a unmet need group. Some people want even that 3 months of benefit, right? Some people don't want to take all those risk factors, all those side effects of therapy of niraparib. They don't want to take it, but it is always an informed decision to patients saying that what, it could be 3 months. But of course, if your profile is good, because it's not just about HRD being proficient, there are a lot of other factors as well. What is the visible disease status, or what is the stage of disease? All of that also plays a role in translating a response to this niraparib. Definitely, it will be an informed decision. 3 months of benefit. Do you really want to do it, or do you want to just stick to bevacizumab? A lot of us put patients on bevacizumab. Bevacizumab also gives you similar benefits. So it will be an informed decision for the patients to take.
Yeah, I agree. Also, one important thing that there was a post-hoc analysis from the primer trial that all those patients who were on statins, they did significantly better as compared to those who were not. So this was just a post-hoc analysis, and maybe some synergy would have been there.
Dr. Ankit, your voice is not audible.
Yeah, it goes off at the it went off at the end, Dr. Ankit.
Am I audible now?
You're
Not
audible,
really.
but very faint. Your
Very
voice is very
faintly.
faint.
I'll just put that comment in the chat box. Maybe we can move
Now
forward.
you're audible.
Now you're audible, and then it just fades off.
Yeah, I was saying that there was a post-hoc analysis from the primer trial which showed that adding all those patients who were on statin for any other reason, they did much better as compared to those who were not on statin. So that also shows that there is some synergism between the niraparib and the statin. So just wanted to add that.
Okay.
Yeah. Thank you so much, ma'am.
Thank you so much.
Yeah, we can move forward.
To discuss the updates in systematic therapy and management of endometrial cancer, I invite Dr. Piyush Bajpai, medical oncologist, HOD and consultant, Manipal Hospital, Delhi. Welcome, sir.
Yeah, thanks to Dr. Ankit for giving this opportunity. So just to share my presentation. I hope it's visible there.
Yes, sir.
Yeah. Okay. So just taking you through the updates in systemic therapy and management of endometrial carcinoma. So this is basically a sponsored session. And so the agenda I would be taking you through is what is the rationale, strategy, and landscape for ICI in endometrial carcinoma. ICI in second line endometrial carcinoma, the trials I will discuss is Garnet and K9158, immune checkpoint inhibitor with chemotherapy. The three trials I'll just go through is Ruby, K9868, and Duo E. So just to take you through the background that as we understand that in India, it is an important disease burden, which we are seeing third most common gynecological cancer in India, and the reports are approximately 17,000 new cases every year, and 5-year prevalence rate is 53,000. So this is what it is, and what we see is majority of our endometrioid and 10% are serous in histology. So now the serous histology is actually contributing a lot of mortality, 40% of mortality over there. So just to highlight on the mortality part. In terms of the treatment options available, we know that surgery is the mainstay, but in advanced disease patterns, we have chemoradiation. Chemotherapy has been the backbone, and now chemoimmunotherapy is coming up, as we will discuss. Biomarker-driven therapies, basically, especially in certain subsets, as defined over here, are being tried and are seeing the success. So chemotherapy has been there, and of course, there was a build-up on single agent versus double agent, as you can see through the various columns. That, as you can see at the end of the column, the triplet regimen TAP versus paclitaxel carboplatin, so GOG 209. So you can see that the median PFS was 13 months. So it is definitely the median overall survival going up to almost 37 months. Now, so you add on chemotherapy, but then you will not get patients who would tolerate such sort of triplet regimen. That's the challenge that you would get. So, I mean, like what we learned from TAC in breast, likewise over here, because these patients would be more than 60 years of age or obese. So those challenges would be there. So what has been the advancement? I mean, right from 1961, when systemic therapy was being brought in, progestin for the hormonal treatment of endometrial cancer, we understand that, yes, we still use basically hormonal therapies in endometrioid variant, and chemotherapy established itself in 2004. And then we have a game changer over here. That's the TCGA classification coming up. The molecular subgroups were divided, and you have now the PROMISE trial, that is the proactive molecular classifier for endometrial cancer coming up. So that was in 2017, and you had then the trials based on that strategy. And pembrolizumab was used in previously treated deficient MMR and MSI high solid tumors in 2017 and gained the approval of the FDA. Likewise, in 2021, dostarlimab in a similar population gained the approval in the EMA, and also pembrolizumab and lenvatinib in previously treated non-DMMR population. So that was the keynote 775 over there. And of course, in all comers, it gained the approval. So pembrolizumab in previously treated deficient MMR and MSI high in 2022 was there. And then dostarlimab again in primary advanced or recurrent deficient MMR, MSI high endometrial carcinoma, along with chemotherapy, gained the approval in US and EMA FDAs. And in 2024, basically, it was the Pembro combination and the Durva combination of chemotherapy which actually gained the approval. Also, the extended approval did come for dostarlimab as well. So not given in the slide over there, but for dostarlimab, again, the extended approval was there for this particular setting of all comers. So rationale for immunotherapy. Now, in endometrial cancer, why do we use immunotherapy? So we understand that MSI high is something which is there in endometrial cancer. This has been seen, with the subclassifiers of the PROMISE strategy. We understand that MSI high are associated with high neoantigen loads and number of TILs, leading to overexpression of PD-1 and PD-L1. So you can see the graphs for the CD3 and CD8 TILs are higher in POL E and MSI as compared to MSS over there. The PD-L1 Also, the bars are higher for the PD-L1 expression in poly and MSI, and also microsatellite stable situation over there. So endometrial cancer has the highest recurrence of deficient MMR and MSI among solid tumors. So it's almost going up to 20 to 25 to 30%. You can see over there that these many cases you can get if in case you do your MMRs, immunohistochemistry, or do the NGS, and you can get these many cases. So you must do for endometrial carcinoma this particular test. So again, the same thing that this is pretty much high. The MSI is high. Also, the TMB is also an important factor over there, which is high. In this, TMB high only would be there in this subtype. In particular. So basically strategies for immunotherapy in endometrial carcinoma. So there have been a usage of chemo immunocheckpoint inhibitor, immunocheckpoint monotherapy, immunocheckpoint TKI combination with lenvatinib and pembrolizumab, as we see, and PARP inhibitor combination. So the NCCN guidelines basically are showing that yes, in therapy for recurrent in second line, I would start from the right side of the slide. So this is definitely there that pembrolizumab along with lenvatinib in proficient MMR. So that's what is important, that this is a difficult subset to treat. Well, immunotherapy is there in the deficient MMR or MSI high in the second line. So dostarlimab is there, pembrolizumab is there, all would work. So avelumab and nivolumab would work. So coming to the first line. So first line, you have in stage 3 and 4 endometrial carcinoma, the triplet combination, the combination of chemotherapy and dostarlimab in stage 3 and stage 4. And then you have pembrolizumab over there. And then you have durvalumab also over there in stage 3 or 4 endometrial carcinoma, only in deficient MMR tumors. And for primary or adjuvant, basically, now here is the catch point that this is basically there would be some residue left behind. You should have measurable disease probably, because these are potentially inoperable situations where you are using this. So that needs to be understood. It's not typically adjuvant where the immunotherapy has been approved. The Keynote B21 trial actually did not meet its endpoint. So we are still waiting for that adjuvant scenario. So important thing is that the difference over here is you have a variant histology coming up, including carcinosarcoma in the dostarlimab trials, basically. So this is how it looks like typically, that there would be these categories as I discussed earlier. And for again, the systemic therapy, as if in case there's a HER2 new positivity, then actually the preferred regimen for this thing would be a trastuzumab based treatment rather than immunotherapy based treatment. So coming to the immune checkpoint inhibitor monotherapy. So there are a couple of trials which are being discussed today, and that is Garnet and the KN158 basically. So trial design for both was a basket trial and single arm for both the groups. So primarily they were phase 2. So treatment was for dostarlimab 500 mg. Dostarlimab was given every 3 weeks for 4 cycles, and then 1 gram or 1000 mg every 6 weeks until progression. And pembrolizumab on the other side was 200 mg for 3 weeks for 35 cycles or until progression. The primary endpoint was overall response rate, and secondary PFS and overall survival, immune overall response rates, IR-DCR and PFS, and duration of response. So again, in Keynote 158, it was duration of response, PFS, and OS. This was the basic epidemiology. I would not go into the detail, but you can see the prior lines of therapy in both the trials. They were actually including more of first line therapy, one line therapy being given, Second line were 2 lines given was lesser, and of course more than 3 lines were nearly 12% in Garnet and 28% in Keynote. So if you look at the overall response rates, and you can see 45% over there, 48% in Keynote 158, and complete responses, you can see almost 16%. The important point is that in MSI deficient population over there, you will definitely get some good responses despite them being heavily pretreated. However, the important point is the earlier you introduced immunotherapy in such a population also, it would be a better response rates as compared to introducing it later. The important another thing was that at 24 months, 83% of the patients were maintaining their response in the Garnet trial. So that's important. Likewise, at 24 months, nearly 73% in the Keynote trial. So this was it, that 6 months PFS median PFS was 6 months in the Garnet, and likewise for the Keynote, the median PFS was there similar. And if we talk about the combination of chemotherapy, so where we need to actually look at the populations beyond the MSI, so we need to add something more, because we understand that immune checkpoint inhibitors in a proficient population of MMR will not do alone great. However, there was a population in the Garnet trial where the proficient population was also doing fairly okay, and that was around 10 to 15% of those patients where the TMB alone was high actually. So that basically gives us a concept that you need to do something beyond immunotherapy, and that was the concept was to add chemotherapy, and therefore the design of Ruby trial took place. And the eligible patients over here were histologically or cytologically proven advanced recurrent endometrial carcinoma, stage 3-4 disease patterns. They had low potential of cure by radiation therapy or surgery alone or in combination. There were histologies other than the endometrioid also taken into consideration in front of you as late. So they were treatment naive to systemic anti-cancer treatment or had a recurrence or progression at least 6 months before the therapy was given, so more than 6 months before. And stratification was as per the MSI, prior external pelvic radiotherapy and disease status. So it was 1:1 randomization with chemotherapy and dostarlimab, and with placebo and chemotherapy alone. So dostarlimab was continued every 6 weekly thereafter up to 3 years. And on the other hand, it was placebo IV given 6 weekly up to 3 years, and follow-up was there. Primary endpoints was PFS by investigator and overall survival, and secondary endpoints as laid in front of you. So just to go through the important highlighted in bold category B over there, that's patient should have had primary stage 3C1 disease with carcinosarcoma, clear cell, serous or mixed histology. So this was basically other histologies also allowed over there. So we must understand that this was 3C1 population, and this was the basically the epidemiology, the various distribution of disease patterns in and subcategories. So you can see that measurable baseline disease. So there were certain patients in this particular trial where the measurable baseline disease was not there. That's important, and I will tell later. So a high proportion of high-risk histologies was observed in Ruby trial. So as you can see, carcinosarcoma also included in MSI high, and also overall subgroup and other populations, including serous, which was approximately 20% over there in overall. So these were also included. And PFS as per investigator, so in MSI high population, so you had definitely the hazard ratio was 0.28, and median duration of follow-up 24.79 months. So there was a good separation of curves, as you can see over there. PFS, as per investigator, for proficient or MSS population, so hazard ratio of 0.76 and risk of progression or death was reduced by 24% over there. So there was no evidence of any hyper progression taking place, and that's important. If we look at the overall population, so risk of progression or death was reduced by 36%, so with a hazard ratio of 0.64. So updated overall survival, which was there, that risk of death was reduced by 31%, despite high proportion of patients in chemotherapy arm receiving subsequent IO. And risk of death was reduced by 68%, despite a high proportion of patients in chemotherapy arm receiving subsequent IO. So this is the updated overall survival with the risk of death reduced by 21%, despite 37% randomized to CP arm receiving subsequent immunotherapy treatment. And you can see that the other histologies are also getting benefited over there in these in the forest plot. So you have the endometrioid histology, which is almost 55%, carcinosarcoma distribution is 10%, and other various histologies are also there, including the serous adenocarcinoma. So if you look at the objective response rate in proficient, let's see in the proficient population of MMR, you can see that it was around 68% with dostarlimab and 63% with the placebo group. So durable response, if we see, it was nearly 34% more than 12 months durable responses. So 34% versus 21.6%. So in terms of adverse events, where dostarlimab was added, not much of a difference, as you can see in terms of the adverse events being there. The grade 3 slightly more in dostarlimab, but not very significantly different. Then talking about the various trials, DUO-E and the NRG-GY018, the other trials. So taking you through this, this was how basically the population was. Randomization was 1:1 in all these trials. And if you look at the deficient MMR treatment and control, so this was the distribution. And primary endpoint was overall survival in Ruby trial, and in Keynote and DUO-E, it was PFS. So PFS in the first line therapy in proficient MMR group. So if you look at the dostarlimab group, it was 28.4 months versus 18.8 in pembrolizumab. There was this difference again, which was statistically significant. If you look at the durvalumab olaparib arm and durvalumab arm, so there was, with the addition of olaparib, there was this different starkly seen. So for durvalumab, for dostarlimab, again, overall survival in the first line proficient MMR group, it was the curves were clearly separated over there. So median duration of follow-up for Ruby was 25.4 months, and median PFS not reached versus 7.7 months, and hazard ratio of PFS was 0.76. If you compare with the Keynote 868, HR was 0.54. And for DUO-E, basically, it was 0.57 for olaparib and 0.77 if in case olaparib was not there. So olaparib is definitely making a difference over there in especially the population where proficient MMR is there. In terms of overall survival data, so overall survival in if we look at the MMR proficient subgroup, 34 versus 27 months, the hazard ratio being 0.79, p-value of 0.049, so which is significant. And Keynote 868, it was also a positive trial. So basically, no, so this was overall survival was not much different. And in Duo-E, it was non-recordable. So key takeaways was that the benefit of immune checkpoint inhibitors with chemotherapy in first-line endometrioid cancer is more pronounced in deficient MMR and MSI high patient. In MMR proficient and MSI stable cohort, all the three trials show 10% improvement in PFS compared to the placebo arm. The magnitude of PFS benefit between ICI was highest in durvalumab olaparib, 15 months, followed by 13.1 in pembro, followed by 9.9 months in dostarlimab. So the control arm PFS was comparable between the studies. However, the slight increase in median PFS did not reflect the median overall survival in proficient MMR population, where dostarlimab has the highest median overall survival of 34 months, followed by 27.9 months for pembrolizumab. And Duo-E, the data maturity is still not, it's just 28%. In second line endometrial carcinoma, deficient MMR patients get maximum benefit of IO, both in terms of ORR, PFS, and overall survival. And in second line endometrial cancer, dostarlimab in MMR proficient show overall response rate was also seen a small number of patients. However, their duration of response was long. So thank you.
Thank you, Dr.
Thank you.
Piyush, for highlighting key practicing changing updates. Do we have any questions? If not, we'll move on to our next speaker, Dr. Kancha Chabra, Assistant Professor, Medical Oncology, American Oncology Institute, Ludhiana. She'll walk us through ESMO updates across GU cancers. Welcome, ma'am.
So very good evening to all. Thank you, Dr. Ankit and organizers for giving me this opportunity. So I'll be speaking about ESMO Congress highlights in the genitourinary cancers update 2025. So basically, I have 6 trials to discuss, and I have to discuss that in 15 minutes. So without any delay, let's start with the first trial, which is the perioperative enfortumab vedotin plus pembrolizumab in participants with muscle invasive bladder cancer who were cisplatin ineligible. So this is a phase 3 Keynote 905 study. The study design was very simple. Patients with muscle invasive bladder cancer, either node positive or T2 to T4A node negative. So they all were non-metastatic. These patients were taken and these were cisplatin ineligible with ECOG performance status of 0 to 2. So they were divided into 2 arms. One arm received only pembrolizumab and other arm received EV, that is enfortumab vedotin, which was given at day 1, day 8, Q3 weekly, with pembrolizumab, which was given Q3 weekly. For 3 cycles, this combination was given. Then radical cystectomy plus lymph node dissection was done. And after that, patients were either put on observation or EV was continued for 6 cycles plus pembro was continued for total of 1 year. The other control arm, which was pembrolizumab arm, the allocation was stopped early because of the good benefits which were provided by the comparator arm. So the primary endpoint was event-free survival and secondary endpoints were OS and PCR. So the baseline characteristics were well matched between these two groups. As you can see that the majority of the patients, they were of the stage T3 and T4 node negative population. So these were the results. The median event-free survival was not reached in the EV arm as compared to 15 months in the control pembrolizumab arm. But if you look at the 2-year EFS, that was 39% versus 74%, which was almost doubled with a hazard ratio of 0.4 and a significant p-value favoring the enfortumab vedotin plus this combination arm, which was favored by this trial. And if you look at overall survival, that was also not reached and 41 months respectively in EV arm versus pembrolizumab arm. And if you look at the 2-year overall survival, it was 63% in the EV pembro arm it was 63% in the pembro alone arm as compared to 79% in the EV plus pembro arm with a good hazard ratio of 0.5. And if you look at the PCR rates, it was also better in the EV Pembro arm, which was to the tune of 57% as compared to only 8% in the control, that is Pembro alone arm. So there was 48% difference in the PCR if EV plus Pembro was given in the perioperative setting. So naturally, if the patients they did achieve PCR, the EFS was better. It was 87% in the EV Pembro arm as compared to only 67% in the control arm. So the side effects, the majority of the side effects were pruritus, alopecia, diarrhea, fatigue, and anemia, but they all were to the tune of grade 1 and grade 2, which were managed by the conservative treatment. So to conclude this trial, neoadjuvant EV plus Pembro followed by radical cystectomy and followed by adjuvant EV plus Pembro, that is perioperative EV plus Pembro, significantly and meaningfully improved EFS, OS as well as the PCR rates in patients who are cisplatin ineligible. And this benefit was seen across all the key subgroups, and there were no new safety signals which were observed. So to conclude this trial, perioperative EV plus Pembro added to the radical cystectomy plus lymph node dissection may represent a new standard of care in this population, that is in patients who are cisplatin ineligible, with this population is with high unmet clinical need. So coming on to the second trial, which is IM Vigor 011 trial, which is a phase 3 trial of circulating tumor DNA guided adjuvant atezolizumab versus placebo in muscle invasive bladder cancer. Again, the similar population was taken, but here in muscle invasive bladder cancer, after radical cystectomy, the patients were randomized within 6 to 24 weeks of radical cystectomy, and these patients should have no evidence of the radiographic disease, although in these patients prior neoadjuvant chemotherapy was permitted. And the study design was very impressive, because in this study, 6 weekly ctDNA testing was done. It was blood based and Signatera platform was used. So this was done till 1 year post cystectomy. 6 weekly ctDNA testing and 12 weekly radiographic testing was done. And in this trial, at any point of time, if the patients came out to be positive for ctDNA at any time, and there was no radiological progression and there was no evidence of radiological disease, so these patients were divided into 2 arms, where one arm received atezolizumab for a total of 1 year and other arm received only placebo. And those patients who were ctDNA negative until 1 year, they were just put on surveillance. So these were the results. In patients who were ctDNA positive and who received atezolizumab, you can see that the median DFS was doubled. It was 4 months in the placebo arm as compared to 9.9 months in the atezo arm with a good hazard ratio of 0.6. If you look at the 2-year DFS, it was more than double. It was 12% versus 28% favoring the atezolizumab. Again, talking about the overall survival, the median OS was 21 months in the placebo as compared to 32 months in the atezo arm. And if you look at the 2-year OS in ctDNA positive population, it was 46% versus 62%, again favoring the adjuvant atezolizumab arm. So this DFS benefit and overall survival benefit was seen across all the subgroups, irrespective of the T stage, N stage, and you can see irrespective of the PDL1 status, whether it was negative or positive, all these patients, they benefit with the adjuvant atezolizumab in the ctDNA positive population. So to conclude this trial, adjuvant atezolizumab demonstrated statistically significant DFS and OS improvements as compared to placebo in patients with muscle invasive bladder cancer identified at ctDNA positive through serial MRD testing. And those who were ctDNA negative, they had lower risk of recurrence. They were just put on surveillance. So these findings indicate that serial ctDNA monitoring can identify patients with muscle invasive bladder cancer who benefit from adjuvant atezo while sparing patients who test ctDNA negative from unnecessary treatment and toxicity. So coming on to the next trial. So these 2 trials which we discussed, these were in the non-metastatic setting. Now talking about the metastatic setting. So this is disitamab vedotin plus toripalimab versus chemotherapy in first line locally advanced or metastatic urothelial carcinoma with HER2 expression. So this was study design where treatment naive with no prior systemic therapy patients were taken which were of metastatic urothelial carcinoma. And point here to note is that the HER2 positive population which was taken, they were either IHC 1 plus, 2 plus, or 3 plus. All these three were taken as HER2 positive. And to my surprise, there was 70% of the population, they actually had HER2 positivity in this subset. So these patients were also eligible for cisplatin or carboplatin with a good performance status of ECOG 0 or 1. They were divided into two arms. One arm received disitamab vedotin plus toripalimab. So disitamab vedotin is an antibody drug conjugate against HER2, and toripalimab we all know that is anti-PD-1. And this was compared to chemotherapy, GemCis or GemCarbo. Dual and primary endpoints were taken, which was PFS and overall survival. Secondary endpoints were PFS by investigators and the overall response rate. And the results were very impressive. So if you look at the progression-free survival, that was in chemotherapy, it was only 6 months, and it was more than double. It was 13 months in the DV plus toripalimab arm. And if you look at the 1 year PFS, it was 16% versus 54%. It was tripled in the DV plus toripalimab arm. So talking about the overall survival, it was in the chemotherapy arm 16 months as compared to 31 months in the DV plus toripalimab arm. And 1 year OS was 62% versus 79% in the chemo alone versus DV plus toripalimab arms respectively, again favoring the DV plus toripalimab arm. And if you look at the overall response rate, it was 50% versus 76%, and there was 26% difference in the overall response rate, which was better in the DV plus toripalimab arm. Again, the duration of response was also better, and it was 5 months in the chemo arm as compared to 14 months in the DV plus tori arm. And if you look at the 1 year duration of response, it was 19 versus 58%. Again, the safety signals, the main side effects was derangement of the liver function, anemia, alopecia, and asthenia, along with hypertriglyceridemia. But again, these all were of the grade 1 and grade 2, and they were well managed conservatively. So to conclude this trial, so DV plus toripalimab led to clinically meaningful and statistically significant improvement of PFS and overall survival, and the PFS benefit was 13 months as compared to only 6 months in the chemo arm. Overall survival was 31 months as compared to only 16 months in the control arm, and this benefit was seen across all the HER2 expression, whether it was IHC 1 plus, 2 plus, or 3 plus. And so this offers a valuable new treatment option representing a potential new standard of care for the first line treatment for patients with HER2 positive metastatic urothelial cancer. Now coming on to the POTOMAC trial, which is durvalumab plus BCG for BCG naive high risk non-muscle invasive bladder cancer. This is a phase 3 open label randomized study, and the study design was patients of age more than 18 years with non-muscle invasive bladder cancer who were BCG naive, and they were of high risk. So high risk in this subset means either T1 or high grade, that is grade 3, with in situ carcinoma or multiple and recurrent and larger tumors more than 3 centimeter. They were divided into 3 arms. One arm received Durva plus BCG. Now the point here to note here is that here BCG was given induction as well as maintenance, as we usually do, followed by the SWOG protocol, where induction BCG was 6 weeks, then maintenance BCG was given 3 weekly doses at 3, 6, 12, 18 and 24 months. This was compared to durvalumab plus BCG only in the induction arm and BCG alone. So these three were the arms which were taken. And now I'll just talk about the Durva plus BCG, where induction plus maintenance both were given, and this was compared to BCG alone. And you can see that the median DFS was not reached in both the arms. But if you look at the 2-year DFS, this was 82% versus 87%, favoring the Durva plus BCG combination with a hazard ratio of 0.6. And this had no negative impact in the overall survival. It means that the overall survival was also almost similar in both the arms. Again, the main side effects were hematuria, proteinuria, UTI, but these were seen in both the subgroups and these were well managed. So the POTOMAC conclusions were that Durva plus BCG combination given both in induction and maintenance, it gave us a meaningful improvement in the disease-free survival as compared to BCG alone in BCG naive high risk non-muscle invasive bladder cancer, with 32% reduction in the DFS with no negative impact on the overall survival. So POTOMAC supports 1 year of Durma in combination with BCG induction and maintenance as new treatment option in patients with BCG naive high risk non-muscle invasive bladder cancer. So this was about the bladder cancer. Now coming on to the renal cell carcinoma. So these are the first results from the Rampart trial. This is international phase 3 RCT of adjuvant durva monotherapy or in combination with tremelimumab for resected RCC. So here the trial design was that resected RCC was taken and the resection should be complete with ipsilateral adrenal metastasis which should be excised, and if there were soft tissue metastasis it should also be excised, and then the patients were either of intermediate risk of relapse or higher risk of relapse were taken. So a special risk score was taken, or it was instilled in these patients, where it included patients of category PT3, T4, or it was dependent on the nodal status, what was the size, whether it was less than 10 centimeter or more than 10 centimeter, and necrosis of the tumor was also considered to assess this risk. And the patients were divided into 3 arms after assessing the risk. One arm was only put on active monitoring, other arm received durva alone, and the third arm received durva for a total of 1 year at the dose of 1500 milligram, and it was combined with the tremelimumab, which was given 75 mg at week 1 and week 4. So the baseline characteristics were well matched. I just want to highlight here that most of the patients which were taken were of PT3 and node negative status. Both clear cell and non-clear cell patients were taken. So you can look at the disease-free survival in intention to treat population. It was 73% in the active monitoring arm as compared to 81% in the durva tremi arm, which had a better response with a hazard ratio of 0.6. If you look at the higher risk population, this difference was again higher. This was at 61% versus 78%, again favoring the durva-tremi combination. But if you look at the intermediate risk population, this DFS was similar. And all the adverse events, the main adverse events were fatigue, diarrhea, pruritus, rash, and renal impairment. But grade 3, grade 4 was only diarrhea, which was again managed with a conservative treatment. Now, to conclude this trial, that adjuvant therapy with durva-tremi combination following RCC resection improved DFS, but largely in the higher risk population with no unexpected safety signals. And we were also talking about durva alone arm. The results are not out yet. The results of durva alone versus active monitoring, they are expected in next 6 to 9 months. So coming on to the last trial, which is phase 3 trial of lutetium PSMA 617 combined with ADT plus androgen receptor pathway inhibitor in patients with PSMA positive metastatic hormone sensitive prostate cancer. So we all know that we have the approval of lutetium therapy in CRPC, castrate resistant prostate cancer. But here we are talking about hormone sensitive metastatic prostate cancer. So this is the study design: untreated or chemotherapy or any systemic therapy, naive metastatic hormone sensitive prostate cancer was taken with PSMA positive PET lesions, either one or more. They were taken, and those patients should be appropriate to receive ADT plus ARPI. So they were divided into 2 arms. One arm received lutetium therapy plus ADT ARPI combination, and other arm received only ADT plus ARPI combination. So the primary endpoint was radiographic progression-free survival. So this is a slightly different endpoint which we usually see in the other trials. So these were the results. The radiographic progression-free survival, if you look at the p-value, it was very, very significant, and you can see that the graphs, they are well separated with the radiographic progression, which was higher in the ADT ARPI combination, and it was lesser in the lutetium PSMA ADTI plus ARPI combination. However, the median radiographic progression-free survival, it is not reached in the both arms. So you can see that this PFS benefit was seen across all the subgroups, but 2 subgroups I want to highlight, that is irrespective of the age, irrespective of the de novo recurrent metastasis, and irrespective of the baseline PSA levels, this combination benefited in all the subgroups. And overall survival, you can see that there is similar, because the p-value is 0.1 and the median overall survival has not reached in both these arms. But if you look at the overall response rate, the time to PSA progression, time to skeletal events, and time to metastatic CRPC, they all were improved in the lutetium therapy plus ADTI ARPI combination as compared to the control arm. The main side effects with this combination was dry mouth, nausea, constipation more than diarrhea, vomiting, and cytopenias. So to conclude this trial, combining lutetium therapy with ADT and ARPI, it led to statistically significant improvement in radiographic progression-free survival in patients who are PSMA positive metastatic hormone sensitive prostate cancer as compared to the control arm, and side effect profile was consistent with no unexpected safety signals, and there were no significant differences in time to worsening of quality of life or pain. So this indicates that combining lutetium with this combination, it clinically improves and benefits the patients with PSMA positive metastatic hormone sensitive prostate cancer. So my take home message is, in renal cancer, we have seen that the adjuvant immunotherapy with durva-tremi combination, it may redefine the post nephrectomy patients of high risk RCC where this combination is beneficial. In bladder cancer, we have seen that the durva plus BCG combination in BCG naive high risk non muscle invasive bladder cancer, it also gives a potential role for early bladder cancer management. And in prostate cancer, lutetium plus ADT ARP combination significantly improves the disease control in PSMA positive metastatic HSPC. So thank you for the patient hearing, and I once again thank Dr. Ankit and organizers for giving me this opportunity.
Yeah, thank you, Dr. Akansha, for walking us through the important pivotal trials which were presented in GU space in ASMO. So I think it was very well presented, and the take-home message was also very clear. In the interest of time, we'll move forward to our next talk, which is on the role of enfortumab vedotin in relapsed refractory bladder cancer. And to discuss this, we have with us Dr. Randeep Singh. He's a senior consultant and director in Narayana Super Specialty, Gurgaon. Welcome you, sir. Over to you.
Thank you, Ankit. I think in the interest of time, I will keep it very brief. And the current talk is about of role of EV in advanced urothelial cancer in the second line. This is a sponsored session, and the slides have been provided by Estella. And we will go with the regulatory approvals as per our country. So I think I will directly go to the trial. This was EV301. This was a phase 3 trial where single agent EV was used. It is, as we all know, it's a short infusion which goes as a weekly regimen. It goes for 3 weeks on, 1 week off. And that was compared to the second line agents that were available at that time. And those at that time when the drug was started were taxanes, basically docetaxel, paclitaxel, and vinflunine, which we did not have access. This was a phase 3. The primary endpoint was overall survival, and the secondary endpoints were PFS and response rates. So majority of the patients were actually of less than 70 years, but even I mean for those we are worried about starting EV in elderly, there was around 20% of the patients who were more than 75 years of age and they were elderly. What is encouraging in all these EV trials as compared to the previous chemotherapy trials as well as the chemoimmuno trials is the inclusion of the upper urinary tract, though we see very less upper urothelial malignancies. But it is commendable to see that 30% of the patients were upper urothelial malignancies in this trial as well as other first line EV trials also. So the primary endpoint was met, and we can easily see that the curve started separating quite early at 3 months. The hazard ratio was 0.70, which shows a 30% reduction in the risk of death, and the confidence intervals are well respected of 0.5 to 0.8. Coming to the absolute advantages at 12 months, if you talk about absolute numbers, there was around 10 to 12% more patients who were living at the end of 1 year if they have received EV versus taxanes. Similarly, the PFS, though the benefit in PFS in the clinical magnitude terms is not very significant, that is hardly 1.5 to 2 months, though it gives you a very good hazard ratio, but I think the overall survival is quite assuring, which was also the primary endpoint of this trial. Coming to the trend, I think we can skip this, we can skip the response rates. Now the quality of life, because of the toxicity, the quality of life was well maintained. Over the first 12 weeks of treatment, the overall patient-related quality of life was maintained. There was significant reduction in the pain. And in most of the patients, in the other domains, functional and symptomatic, the quality of life was maintained. Coming to the side effects, yes, this drug has toxicities as compared to chemotherapy. The toxicities are slightly different. What you have to remember is maculopapular rash, acneiform rash, which is to be monitored. You have to take care of the diarrhea. You have to take care of neuropathy. The patient shall not have grade 2 neuropathy at the time of entry. You have to take care of the blood sugar levels. The HbA1c has to be less than 8, and the fasting blood sugar shall be around 160 or less, ideally, or less than 200, but ideally less than 160. So you have to watch for deteriorating neuropathy. So any patient with a grade 2 neuropathy, anyone who has a HbA1c which is more than 8, or the fasting blood sugar is more than 200, it will be better to control that and then include these patients. Also watch for diarrhea and myelosuppression, though the myelosuppression is not much, but the diarrhea and GI side effects, apart from skin rash, are the worrisome side effects. Similarly, these are the percentages of the skin rash grade 3, grade 4, which are clinically significant. The reactions are 15% with respect to rash, 5% significant neuropathy. There is some dry blurred vision, but that is less than 1%. And yes, there is 1% infusion related reactions. There are many real world data sets which support the decision making and give you the confidence. To quote, there are European, Italian, American. I'm just quoting one of them so as to not to make it more exhaustive. This is a large multi-institutional retrospective analysis, of course. The PFS and OS are almost comparable. PFS is slightly better, 6.8 months, and overall survival is also slightly better, around 14.4 months. So this was a Unite registry. Also, what is to be remembered is that this is quite interesting from the Unite registry. This is published in ASCO GU24. These are about the variants, and many times you have variants. So whenever you have a report of a urothelial carcinoma which is telling you about variants, please ask your pathologist to mention about the variant. I mean the variant like squamous, sarcomatoid, or adenocarcinoma component. If the adenocarcinoma, sarcomatoid, squamous component is less than 50%, then your response rates are almost similar to the tune of what we expect in the original trial. But if they are more than 50%, then there is a remarkable dip. But still, you can use if you have a mixed histology, especially around 50-70%, if you have urothelial malignancy, which is a minority component, the responses and the PFS OS data will not be that encouraging as of the original trial. But if you have a 100% variant, as seen on the fag end of this algorithm or sheet, the response rates are very poor, and thus suggesting that use of EV in a variant histology, especially squamous, adeno, or sarcomatoid, may not be of much use. So I think in the interest, I mean, to summarize from EV301, there is 30% lower risk of death. That is 12.9 is the overall survival compared to 8.9. There is another 40% reduction in the risk of progression. There is a doubling of response rates, and there was significant improvement in the quality of life when you use EV in the second line with respect to available chemotherapies. And I think this trial is becoming more and more irrelevant now, as we all know that the previous speaker also did talk about perioperative use of EV Pembro, and EV Pembro is also approved in the first line therapy in many countries. Thank you for your patient here. Over to the organizers.
Thank you, Dr. Randeep. Moving on to the final talk for day one that focuses on improving OS and quality of life in unresectable hepatocellular carcinoma, I invite Dr. Nikhil Hemtani, Consultant Medical Oncology, Hemato-Oncology, Patra Hospital, Delhi. Welcome, sir.
So good evening to all my dear colleagues, and thank you, Dr. Ankit, and to the organizers. Can anyone upload the slides?
Sure, sir. Just a minute.
So good evening to all. I'll be discussing regarding the management of unresectable hepatocellular carcinoma, maximizing patient outcomes and improving overall survival and quality of life. Next slide. So, as we know, for advanced unresectable HCC, immunotherapy is the standard of care as per BCLC guidelines as well as for ESMO guidelines. In first line setting, either atezo-bev or the stride regimen is the standard of care, and if the patient fails on this, in second line we have option of TKIs, lenvatinib, after that cabozantinib or regorafenib in that order. So the next slide. So overall survival expected is more than around 2 years with these therapies. So this is these are basically the timeline and how the treatment has evolved for HCC. Initially, best supportive care was the option we had for advanced unresectable HCC, but in 2007 came the SHARP trial where sorafenib was compared with placebo, and it did performed and became the standard of care. Then came, after nearly a decade, in 2017 came Reflect trial where lenvatinib was compared with sorafenib and it showed non-inferiority. And in 2021 came the landmark trial I Am Brave 150, where atezo-bev became the first line standard of care for unresectable advanced SCC. And now we have the option of stride regimen as per the Himalaya trial. Next slide. So coming on to the I Am Brave 150 trial design. So it was a phase 3 randomized controlled trial which enrolled patients with locally advanced unresectable HCC with childhood A disease. Patients were randomized to receive sorafenib 400 mg BD versus atezo-bev 3 weekly until loss of clinical benefit or unacceptable toxicity. The primary endpoints included overall survival as well as the progression-free survival. Next slide. So coming on to baseline demographics and clinical characteristic, so we can see that both the arms were well balanced with respect to age, sex, performance status. Most of the patient had childhood A disease, only less than 1% had childhood B disease. BCLC stage, nearly 80% had BCLC C disease, while around 15% had BCLC B disease. 30% had non-viral etiology, and nearly 70% had viral etiology of HCC. And so both the arms were well balanced, and the study did include nearly 26% of patients with esophageal viruses as well, if those were inactive or had been treated. Next slide. So the I Am Brave 150 included 21% of high risk features as well, which may reflect with the real world patient profile and provide evidence benefit to wide range of patient type. Those patients had poor prognosis and were excluded from other IO trials. And high risk patients, nearly 20% were high risk patient in this trial. VP4, as know it is high risk, around 14% had VP4 disease, tumor more than 50% of the liver, around 5%, bile duct invasion around 2%. So patients who had advanced disease were also enrolled in this trial. Next slide. So we can see that the atezo-bev outperformed as compared to sorafenib. Kaplan-Meier curve separating early, and at around 18 months we can clearly see the benefit, OS benefit, 40% versus 52% with a delta of nearly 12%. Next slide. Similar PFS improvements were also seen in the atezo-bev arm as compared to sorafenib, with improvement in median PFS from 4.3 to 6.9 months. Next slide. Atezo-bev showed a higher overall objective response rate and complete response rate as compared to sorafenib. CR rate of around 8% was seen in atezo-bev versus less than 1% in sorafenib. Objective response rate was around 30% in the atezo-bev arm versus 11%, so significantly higher. Next slide. So coming on to the subgroup analysis, we can see that all subset of patients did better in the atezo-bev arm, except for patients who had non-viral etiology, where the hazard ratio was near unity 1.05. Except for that subset of patient, all of the patients did better in the atezo-bev as compared to sorafenib. Next slide. So there was a post hoc analysis of etiology and outcomes, and so disease etiology and outcomes after atezo plus bev in SEC. This was a post hoc analysis, and you can see that in patients who had non-alcoholic etiology as well, that is fatty liver, the response rates were pretty much similar. CR rates, complete response rate, were around 10% in non-alcoholic fatty liver disease, and it was similar irrespective of the etiology. The CR rates, the partial response rates were similar irrespective of the etiology. So there was no significant difference in the proportion of patients who had a response across etiologies. Next slide. So we can again see that with respect to the progression-free survival and overall survival, there was no significantly difference across multiple comparisons. So irrespective of the etiology, the PFS and OS were similar. So disease etiology should not be factored into consideration when using atezo-bev and likely other ICI regimen for the treatment of HCC. Next slide. So in IMBRAVE 150, efficacy of atezo-bev was observed across etiology, and PFS and ORR benefit for atezo-bev were observed across both non-viral and viral etiologies. And we can see for specifically non-viral, the PFS, median PFS were similar, 7.1 versus 5.6 months, and objective response rates were 27% versus 9%. Next slide. So there was no clear pattern of chemoimmunotherapy in viral and non-viral SCC. So this is the subgroup analysis, and we can see that for in the Himalaya trial as well, for patients who had hepatitis C, the hazard ratio was near unity. And next slide. So and we can see that in I am Brave 150, as I previously mentioned, that for non-viral etiology, again the hazard ratio was near unity. But it is important that these sub-analyses are hypothesis generating only and not conclusive. So there are no clear-cut pattern we can see, and we should not base our treatment based upon the etiology of HCC, as we have seen that in the post hoc analysis that atezo-bev did attain similar response rate and similar PFS and similar OS irrespective of the etiology. Next slide. Now coming on to safety and quality of life. So we know that this is a well tolerated regimen we all have used in our practice. So with BEV, we know that it causes hypertension and proteinuria, transaminitis, risk of bleed. So important to do an upper G endoscopy prior starting bevacizumab. And atizo, as we know, it causes immune-related adverse events. So skin rash, diarrhea, pruritus, hypothyroidism. These are the frequently side effects which we see, but most of them are grade 1, grade 2, and manageable. Next slide. Next, yes. So concept for treatment goal with unresectable HCC. So how do we decide the therapy of choice? So it depends upon the OS prolongation, good direct anti-tumor effect, manageable side effect, preservation of quality of life, and preservation of liver function for subsequent therapy. Next. So what is the prioritized requirement for first line systemic therapy for unresectable HCC? So it should have wide benefit and less toxicity. We want high response rate and low progressive disease rate, long PFS and OS. At the same time, the treatment should be well tolerable with less grade 3, grade 4 adverse events, as well as preservation of liver function so that the patient can tolerate subsequent therapy. Next slide. So it is important that in although cross trial comparison should not be done, but we can see that in the STRIDE, that is the Himalaya trial versus this I am Brave trial, we can see the Kaplan-Meier curve separating early in the atezo-bev versus sorafenib, versus in the STRIDE we can see the Kaplan-Meier curve separating later on after 6 months. So initial response rates are more with atezo-bev, as well as with clear early separation of curves. We get the responses which we desire for. Next slide. So atezo in combination with bevacizumab for management of patient with HCC. This was a meta-analysis and we can see that as per uh, that Atizobev did better as compared to the other treatment arms. Next slide. So it is important that patients who do respond to the treatment have a longer have a probability of better overall survival. So even patient with stable disease had reasonable OS, and progressive disease 19% rate are relatively much lower with Atizobev compared to the newer IO trial, that is 40%. So patient who had CR and PR, the median OS was not evaluable, and who had stable disease, the median OS was around 17 months, and for who had progressive disease, the median OS was around 6.8 months. Next slide. So this is a waterfall plot. We can see that the tumor shrinkage was seen in around 74% of the patient who received the Atizobev combination versus 54% who received sorafenib, which was significantly better in the Atizobev arm. Next slide. So overall survival in patients receiving Atizobev. So patient who had tumor shrinkage did better as compared to patient who did not have any tumor shrinkage. The median follow-up duration was 20 months in tumor shrinkage population and 7.6 months in the non-tumor shrinkage population. So patients who respond did better with the median with overall survival 24 months versus 7.6 months in the non-tumor shrinkage. Next slide. So, so duration of response also was better in the Atizobev arm as compared to sorafenib. It was 18.1 months versus 14.9 months in the sorafenib with hazard ratio of 0.38. Next slide. So three factors of tumor response for long-term survival: high response rate, deep responses, and long responses. And Atizobev satisfy all these three factors. Next slide. So in the subgroup analysis for patients who had VP4 disease as well, which is considered as a poor prognosis, the median overall survival was better in Atizobev arm as compared to sorafenib, with improvement in median OS from 5.5 to 7.6 months. Also, there was improvement in PFS from 2.8 to 5.4 months. Objective response rate was better, 13% versus 23% in Atizobev arm. Uh, so in these subgroup of patients also Atizobev is active with decent response rates as well as significant improvement in OS and PFS. Next slide. So I think we have discussed this. Next slide. So in patients with varices, Atizobev demonstrated efficacy benefit over sorafenib. So it is important to get an upper G endoscopy done to rule out those varices, and the PFS, OS, and ORR benefit were observed among patients who with varices treated with Atizobev. So efficacy outcome among patient with varices, the median OS was 8.6 months in sorafenib versus 17.7 months in Atizobev. Hazard ratio of 0.55. Similar improvement in median PFS and overall objective response rate was seen in patients who received Atizobev as compared to sorafenib. For patients who did not have esophageal varices, the OS was better, although the magnitude of benefit was lesser in patient who receive Atizobev versus sorafenib. So median OS was improved 19.9 versus 16 months with hazard ratio of 0.72. PFS from 4.3 to 6.8 months, hazard ratio of 0.67. So benefit was seen in both patient who had varices or no varices. Next slide. So in IM Brave 150, the majority of bleeding events with Atizobev were unrelated to the varices, and epistaxis was the most common bleeding event with Atizobev 10.3%. The majority of bleed events with Atizobev were only grade 1 and grade 2. Next slide. So this is the AASLD practice guidelines. So it is important before starting you should undergo an upper G endoscopy to rule out varices high risk, that which is a level 5 strong recommendation. And if there is a large varices, So it is recommended at least one session of banding has to be done, and patient has to be started on carvedilol may be considered as an alternative management of varices prior to atezolizumab. And patient with recent GI bleeding within 6 months and those with high risk stigmata for bleed on esophageal varices should be treated adequately prior to starting atezolizumab. Next slide. So, as I've told, we treat as per the BCLC staging, and for advanced stage, treatment is atezolizumab, as we have discussed. The aim is to prolong OS, and patient should be fit, and the liver function should be well preserved, so that patient is subsequently considered for next line therapy. Next slide. Next slide. So the patient-related outcome, time to deterioration of quality of life. So we can see that the quality of life was better in patient who received atezolizumab as compared to sorafenib, and with improvement in physical functioning and role functioning. Next slide. So change in ALB score in atezolizumab. So this was analysis from the IMBRAVE 150, and so up to 30 cycles, patient treated with atezolizumab still maintained ALB grade and continued to receive treatment. This is very important, that patient who continue to receive atezolizumab had preserved ALB score, and these patients are candidates for subsequent therapy with preserved liver function. Next slide. So subsequent therapy rate. So real world data demonstrates preserved liver function, and so it is important that the liver function should be preserved, so that patients are candidate for subsequent line of treatment. And more than 70% patients were eligible for second line treatment with preserved liver function. So this was data from Korea, real world data in Japan, real world data around 100 patients in the Korean data and 34 patients in the Japan. And patient receive atezolizumab. Nearly more than 66% of patients in the Korean data and 88% in the Japan data were eligible for next line therapy. So that is a very important thing, that patients who receive atezolizumab have maintained their LB score and with preserved liver function. Next slide. So real world data, there is 5-year overall survival data from Taiwan, and we can see in this trial that the overall survival at 5 years was 19.6%. This was real world analysis data, which enrolled 54 patients, and most of them had hepatitis B, 68%, hepatitis C, 18%, MVI 55%, VP4 around 7%, and median follow-up was 79 months, and median OS was 19.6 months. And from the data collected in 4 medical centers in Taiwan, led to notable proportion of patients achieving long-term survival with 60-month OS data of 19.6%. Next slide. So to conclude, that I am brave 150 suggests that atezolizumab continued to demonstrate clinically meaningful treatment benefit versus sorafenib, with improvement in OS, PFS, overall response rate, and the safety. We know it's a very safe combination, with majority of patients having grade 1, grade 2 adverse event, very few having grade 3, grade 4, and it has shown longest overall survival seen in frontline phase 3 study in advanced SCC, despite including patient with high risk baseline characteristic, confirming this combination as standard of care for previously untreated unresectable SCC. And the effectiveness and tolerability profile in real world analysis remain consistent with the clinical trial data. With that, I thank you and hand over to the organizer.
Yeah, thank you, Dr. Nikhil, for taking us through the data of tolizumab, and we have now a very good and rich experience
Thank you,
you.
Dr. Himtani, for that impactful session. To formally conclude day one, I request Dr. Ankit Batra to share the closing remarks.
Yeah, thank you, Avni. What I'm saying was to thank Dr. Nikhil for taking us through the nuances of the with the treatment with bevacizumab and how to optimize our patient before taking them through the IO plus VEGF inhibitors. So, with this, conclude our day one of this Onco Edge redefining cancer care webinar. And once again, I thank everyone for taking out time and joining with us this evening and enriching everyone with the latest update and the data which we have in the recent past. So, thank you everyone for joining, and thanks to all the our academic partners who have sponsored these sessions. So we'll meet tomorrow at 7, and tomorrow we'll be going to discuss about the updates and the latest data regarding the lung cancer. So thank you everyone and good night.